Perioperative, narrated by Lisa Shiver. The goal of perioperative care is to assist the clients and family through the surgical episode. We want to promote positive outcomes, obviously, and help clients achieve their optimal level of functioning and wellness after surgery. The nurses may play very different roles. You might be involved in direct or indirect care and or management of the patient who is having surgery. Some of the roles that are actually found within the operating room include the circulating nurse, the scrub nurse, the registered first assistant, and a certified registered nurse anesthetist. And we'll talk about those roles first briefly. With the circulating nurse, this is generally the person that is with the patient before they enter the surgery suite. And they will be going in and out of the surgery area. This may also be the person that is with the patient after the surgery is completed. The scrub nurse plays more of a role in the surgical suite itself. They will be getting supplies, monitoring the patient throughout the surgery and things like that. A registered first assistant works closely with the surgeon and may actually assist in the procedures during surgery. A certified registered nurse anesthetist may actually administer the anesthesia during the surgery. There are other roles that are also very important, and these include the manager or the educator. Usually the manager of a surgical unit is a nurse or has nurse training, and they just look for ways to improve. They may deal with staffing. They just keep the surgical or the surgical suite running. And then the educators obviously are involved with staff education. First, we're going to talk about the preoperative phase, and this is where we are going to be probably more involved unless we take a position working in surgery. We need to identify risk factors that may occur during this preoperative phase, and it's vital to identify these risks or any complications that may occur. So it's going to be our job as the floor nurse to identify these risk factors. There will be a detailed medical and health history performed on the patient that will inquire about allergies, diseases, any medicines the patient has. And it's really, really important that we do a really detailed health history on someone. The psychosocial history may include things such as their religious practices, because we may have to honor religious practices during surgery, and that might be related to the use of blood products, or it could be something as exposure of the skin. Maybe they like to have their skin covered more. Support system is also important to note. Who is the patient's support system? Who's their family? Who's going to be there with them to help them through this process? With the physical examination, we're going to do a good exam from head to toe, and we need to determine what that patient's baseline assessment is. We also need to consider their cognitive assessment. Look at sensory issues. Do they have any sensory deprivation? Are they able to see? Do they use hearing aids? But also, we need to evaluate their learning impairment. What is the educational level of the patient? Do they understand what's going on with them? Diagnostic testing may include a CBC or a complete blood cell count, which will be looking at the patient's H&H. We will consider this because if we suspect the patient is going to have blood loss during surgery and their hemoglobin and hematocrit are already low, well then the patient may have to have their surgery delayed if it's a non-emergent surgery. The chemistry panel will allow us to look at BUN and creatinine levels so we can evaluate their hydration status. We also can look at liver function tests, make sure the liver's functioning correctly so it can eliminate any anesthesia that may be used. Also on the chemistry panel, we need to know about the patient's electrolytes. If there's a severe electrolyte imbalance, then the patient probably won't go to surgery unless it's, again, an emergent situation. Urine analysis, we need to make sure there's no bacteria present in the urine. Chest x-rays, make sure we see nothing abnormal in the chest as far as heart and lungs go. If a patient is scheduled for surgery and we do a chest x-ray and we see a big enlarged heart or we see pneumonia on the x-ray, the surgeon may want to delay the surgery until either the infection is cleared or till a cardiologist evaluates the patient. And patients may have an EKG ordered as well, especially if they're over the age of 50, prior to surgery to identify any heart arrhythmias that may be undiagnosed. If patients are on blood thinners, especially heparin, you would expect the patient to have a PTT level. If they have been on Coumadin, you would expect the patient to have a PT level. And something interesting about Coumadin is patients who have scheduled surgery may have to be off their Coumadin for up to 2 weeks beforehand, because Coumadin does stay in the body a lot longer. Heparin, on the other hand, may be gone within 90 minutes, so patients could have heparin up till the morning or the day of their surgery. Informed consent is a very, very important process that has to happen prior to a surgery, but not only surgery. Any invasive procedure requires informed consent. And this signifies that the client has been told about and understands all aspects of a specific invasive procedure. This informed consent that is signed by the patient or whoever their guardian is must accompany the client to the OR. You have to write out the full name of the procedure when you are filling out an informed consent. You can't have an informed consent for an ORIF. You would have to write out that this is an open reduction internal fixation of the left hip or whatever the surgery is. So you cannot use abbreviations on an informed consent. Everything has to be spelled out. And in some cases you might have to look out how to spell these things. Again, these informed consents are necessary for each invasive procedure. It may not necessarily be a surgical procedure. Maybe the patient's going to have a central line inserted. Well, there should be an informed consent that's signed prior to that, unless it is an emergency situation. Informed consents are not valid if the patient is currently sedated. So you want to make sure they sign the informed consent prior to receiving sedation. If it is a patient that has been medicated or they are sedated, we can have a loved one or an immediate family member, and that usually is their spouse, their parent, or a child of that patient to sign. Telephone consent is sometimes the only way we can get a consent from someone. Maybe the patient is unresponsive and there's nobody there with them and we need some consent, or we need permission to do a surgery and the patient's unable to make those decisions, or they've been sedated. Then what we have to do is have 2 nurses, licensed personnel. They both get on the phone, they both listen, they both talk to this person who is either the spouse, the parent, or the child of the patient, and they have to tell us, yes, they give permission. And then we document very carefully who we spoke to, what they said, and then that they did give permission or they didn't give permission. And then both nurses need to sign that they heard this. So we can get telephone consent. It just requires a lot of good documentation and 2 nurses actually hearing that person consent for the patient. Something that's really critical with informed consent is the surgeon must explain the procedure in terms and language that the client can understand. With informed consent, this surgeon or the doctor is always responsible for initiating consent. Now, there are different degrees to how well physicians handle this. Some physicians will do really well. They will make sure the patients understand everything. But then there's some physicians that will walk in and tell a patient they're going to have a cabbage done, and they walk out with no explanation, don't answer questions or anything like that. So ideally, the doctor is the one who must initiate the informed consent and must explain the procedure in terms and language that the client can understand. the nurse is responsible for ensuring that the client or the legal guardian understands. So we kind of come in and do the cleanup. We're there to make sure they understand, put it in simple terms, and then answer any questions that the patient has. If the patient is still not sure or still does not understand, we can request that that physician come back, because we cannot have the patient sign that form if they're not totally in agreement and understand what they're signing. Okay. During this process, pictures and diagrams may be used, and sometimes that's beneficial depending on what we're trying to explain, and also the educational level of the patient. In some cases, we may need to use an interpreter. Be careful with this as well. Ideally, you would want interpreters that are not related to the patient, because sometimes the patient feels like they can't be open with information if a family member is the interpreter. So if we need to, we can use interpreters, but you must document who we used as well as an interpreter on the consent form. Informed consents must also be signed for anesthesia. So when a patient is going for surgery, there are going to be two different consents signed. One for the procedure itself that's spelled out, and one for permission to sedate the patient or use anesthesia. And the anesthetist should be the one that actually comes around and talks to the patient and does a little assessment on them and explains the anesthesia. Then the question comes up, well, how old do you have to be to consent? In the state of Alabama, and this does vary from state to state, you have to be 14 years old or older, or you have to be an emancipated minor, meaning you live independently, you're self-supporting, you're married, or you have had a child. You actually can be considered the age of consent. But in Alabama, if you're 14 years old, you can sign your permission slip or your informed consent. As far as the physical care goes, when getting a patient ready for surgery, we'll have to do a good skin prep, and the doctor will specify in most cases what he wants us to do or how he wants us to prep the skin. And this may be something that you help participate in as the nurse, but you also may be delegating this to your techs or your care assistants. There are showering and bathing protocols. The doctor will specify possibly a special soap or an antimicrobial soap that he wants the patient to use. Also, we need to note, is the patient allergic to iodine, because that may come into play in the surgical setting. We're moving away from iodine, but it still is used a good bit in the hospital. Depending on the procedure, we may have to shave the patient to prep them. So it's going to depend on what procedure is being performed. And with the hair removal, there's several different ways we can do that in the hospital. Again, it depends on your patient. Disposable razors are generally not used, because that actually can cause open lesions on the skin. It'll just remove that upper layer of the dermis. So electric razors are ideal, but again, it's going to depend on your facility and what procedure is being done about the hair removal. Preparation of the GI tract may be ordered. The patient may have to undergo Go Lightly or different GI preps the night or the day before the procedure. And the reason we would do that is if the procedure involves the GI tract, we would want it to be free of stool, basically. Enemas may be needed prior to arrival or at the hospital, again, depending on the procedure. An NG tube may have to be inserted to decompress the GI tract. With the patients, all of them, if they're going to receive anesthesia, will be NPO, and this is nothing per os. And NPO means NPO, but you have probably seen some exceptions to that rule. Most physicians will write NPO after midnight with anticipation that the patient would be going to surgery in 8 hours or first thing in the morning. Explain why the patient is NPO. You may have to remove food or water from the bedside at midnight and check on them, because sometimes food and water appears in the room, maybe by accident or family brings it in. Put an NPO sign on the door and above the head of the bed just to notify everybody. Make sure dietary some hospitals are notorious. They forget to cancel the patient's tray. So a tray arrives, and the little guy that brings the trays up, he takes it on in the room and doesn't realize that the patient's not supposed to have anything. And the patient thinks, well, I got my tray, I'm supposed to eat it. So make sure that all your bases are covered. And then also inform caretakers or family or anybody that may be coming in and out so they know not to give the patient anything. Surgeries have been canceled because the patient accidentally ate breakfast, and that makes sense because we don't want them to aspirate when they're under anesthesia. But just think how expensive that is for the patient to stay one more night in the hospital just because they ate breakfast. So good communication is very, very critical. There is an exception to the NPO rule. If the patient's on life-sustaining medications or they have cardiac disease, we probably need to give their heart medications with a tiny, tiny small sip of water. Of course, we don't want a patient having arrhythmias because we didn't give them their heart medication. So it's going to depend on what the drug is. If it's something life-sustaining, we think about digoxin or amiodarone or some of those cardiac drugs we'll study more later. Give them with a small sip of water. Reassure the patient that this is okay, because some patients we tell them don't eat anything, don't drink anything, and then we take them their medications and they're hesitant to. But reassure them that this is okay, and then make sure you document the medication and the amount of fluid taken on the client's chart. With their nutritional care, post-op, and this is kind of a weird place for this slide to be, but post-op, what we're going to be looking at is they're going to need carbs to help increase their energy. They'll need high protein to assist with wound healing, and we may have to supplement their vitamins or supplement their diet to encourage healing. And vitamin C is really beneficial for healing. Vitamin K will increase their blood clotting times. And we may have to use TPN for these patients as well, but we need to make sure they are nutritionally balanced before and after surgery. But of course, prior to, if they're NPO, they are NPO. We also need to perform good preoperative teaching with the patient. And I've never really thought about this, but it is very, very true. Good teaching ahead of time may determine the outcome of the surgery. If the patient knows what to expect and when to expect it and kind of how things are going to happen, the patient's going to heal much faster and the outcome's going to be much, much better. So good preoperative teaching is critical. This does have to be individualized for each patient. We can't just use one standardized teaching plan for everybody because it won't be that way. We may have to give written or oral instructions beforehand, and make sure the timing is also appropriate. If somebody is having, maybe they've had a massive heart attack and we're taking them in for emergency bypass surgery, we're going to be very limited to our good timing to do preoperative teaching with the patient. Again, pay attention to timing. We want to make sure we're choosing the appropriate time, and we have to take that into consideration. We also need to consider the patient's ability to communicate. Do they wear hearing aids, glasses, and they need any assistive devices, interpreters? And also older adults. They might be slower in comprehending what we're trying to tell them. Explain all the nursing care and any possible discomfort. If something hurts and we know it hurts, we don't need to lie and tell them that it's not going to hurt. So it's very important that we are honest with our patient, make sure they know what to expect. Turn, coughing, and deep breathing is also very, very important. I'm going to address the deep breathing and coughing first. With deep breathing and coughing, it expands the collapsed alveoli in the lungs and prevents post-op pneumonia. So it is critical with all surgical procedures that we get the patient turning and deep breathing and coughing, because we don't want pneumonia to set up. It's going to remove those secretions from the airways. We demonstrate how to do it and then ask for them to return demonstration for us. Usually 5 to 10 times an hour would be ideal during the post-op phase. And if it is painful to do, which it very well may be if they've had an incision or surgery on the trunk, maybe belly or chest, it's difficult to do coughing and deep breathing. So site splinting is recommended. And they could take a pillow and press it against that site for support and then do the coughing. Incentive spirometers are very beneficial. You may see that abbreviated as IS, and that's just another way where the patient can visually see how well they're doing with their deep breathing. And then recommend them to do their coughing and deep breathing when the commercials come on TV, if they're watching TV. So every time a commercial comes on, or a commercial segment, then do coughing and deep breathing, and they'll probably get their 5 per hour in. The turning exercises, teach the patient beforehand how we're going to turn from side to side and utilize those bedside rails. A lot of times patients see those as a hindrance, but they're there to help the patient turn. We also will teach the patient about preventing venous stasis, thrombophlebitis, pressure ulcers, and respiratory complications. If they're unable to turn themselves, it is our responsibility to make sure they are turned at least every 2 hours during the post-op period. And again, this could be active or it may be passive. With pain control, we need to do good teaching as well. We need to teach the patient how to communicate the level of pain. Tell them we'll be using this 1 to 10 scale. And again, we're telling them this ahead of time. Under treatment is unacceptable. Patients shouldn't have severe pain. That is just unacceptable. Reassure that addiction will not occur in a short period of time, because some patients are afraid to take medicines because they're afraid that they will get addicted, or maybe they've had a problem in the past. But we sure don't want them having pain also. They need to also know that they can ask for medicines immediately when they become uncomfortable. Don't try to bear through it, because chances are it's going to get worse. Anticipate increased pain with movement and breathing, coughing exercises. With dressing changes after the patient has surgery, we may have to pre-medicate them before we ambulate or do dressing changes. Make sure the patient, if they have a PCA pump, that they're familiar with how a PCA pump works and how it will be operated. Or let them know about any IV medications or epidurals. Let them know what to expect. Also teach them about tubes that may be present in the post-op phase, such as Foley catheters. Tell them they'll have a tube in their bladder, or they'll have an NG tube in their nose. Teach them about Penrose drains, or Jackson Pratt drains, or hemovac drains, anything that we anticipate the patient may have, so at least they'll know what it is when they come out of surgery. Also, the IV site is usually going to be started before surgery. It always is going to be needed with a surgical client. You may be starting the IV as the floor nurse, or they may start it when the patient gets to surgery. You must have a 20 gauge or larger IV site. Your pre-op checklist is going to include all known allergies recorded, an allergy wristband if indicated. They may need to be blood banded. It'll include their baseline vital signs, their I&O documented so we can compare that to after surgery. We'll need an ID wristband present, make sure it's spelled correctly, it's the right patient. Informed consent signed and on the chart, make sure the procedure is also correct. Also, along that line, make sure we've got the right, if we're doing surgery on maybe the right side or the left side, make sure that is correct. Have the patient point to the side that we are doing the surgery on. There have been cases where the patient had maybe needed a left knee replacement, and the informed consent said right knee replacement, and they ended up getting a new knee on the wrong knee. So make sure, be so careful, and make sure we get the right right side marked. And that's what I mean by skin prep's complete if ordered, and the site is also marked. Make sure that the patient says, yep, that is the right side. Sometimes I've heard of surgeons coming in and they'll write their initials where they're going to do the surgery. We also want to check our IV lines, use extension tubing if needed, make sure the enemas are done. So this is our checklist, making sure everything is taken care of prior to surgery. Make sure your IV lines are patent too. Just because the lines are there doesn't mean they work, so make sure everything's working without complication. The patient should also be NPO for the last 8 hours. Remove everything but the gown, and when I say remove everything, you are taking off everything the patient has. If they have dentures, if they have nail polish, if they have prosthesis of any kind, if they have a bridge in their mouth that they can take out, if they have jewelry, they take off everything you can take off a patient except the gown. In some circumstances, we may have to give preoperative medications. And these are used to decrease anxiety, also dry up secretions, and reduce side effects of anesthetic agents or induce amnesia. Some patients may be ordered a hypnotic or a barbiturate the night before surgery just so they can get a good rest. Medicines may be ordered on hold. The doctor will write on hold or on call to the OR. And what this means is when the surgery team or transport or whoever says, hey, we're coming to get our patient, that's when you give the medication. You would give it, that's on call. So that's when they call, you give the medication. And we may be given a narcotic. We may be given barbiturates again. We may be given a Valium or an Ativan or a benzodiazepine to help relax the patient. But most patients are going to receive an anticholinergic. And anticholinergics dry everything up. So what this does while the patient is sedated, it prevents them from aspirating any GI fluids. It dries everything up. Sometimes the on-call medicines or on-hold medicines will be given in the OR, but it'll be clarified when this specifically is supposed to be given. So it could be the holding area or on the nursing unit. Make sure that informed consent is signed first. If you're getting the informed consent signed and surgery's on the way up, this better be an emergency situation. I hope you've planned further ahead of time and had all that taken care of. Always consider the client's safety after you medicate them. Side rails up ×2 and document that. Also document that the call light is within reach. Then you'll have to watch for possible side effects depending on the medication that's given. But generally those are given right before they go to surgery, so they're not going to be with you on the unit too long. When the patient is transferred to surgery, they go by stretchers. Side rails will always be up. Make sure they have appropriate covering. It wasn't long ago I saw a patient going down the hall and all they had on was a gown, no covers, and I thought, I bet they wish they had a cover or a blanket. Send the medical record to the surgery unit with the patient, and then we can go ahead and set up that room for their return if they are returning back to that same room. Go ahead and get it cleaned up, get it ready, elevate that bed, change the linens if you need to. Go ahead and prepare the room for surgery return. If you're going to wait, the patient will beat you back. They'll beat you into the room before you have a chance to do that. Then, of course, direct the family to the designated waiting area.